and welcome to the Nurses and Hypochondriacs podcast. Nurse John Canion. Of course, you're a nurse practitioner. So I sent you a question, which this question just popped out of my head, which I think is great to start this episode. How would you describe your nursing career, John, if it was a ride at Disneyland, or if you've never been to Disneyland, like a ride at an amusement park?
It's been a hot minute since I've been to Disney. My kids are old, so it's been a hot minute since I've been to Disneyland. Oh, I don't know. It's been I guess like Splash Mountain repeatedly, going up the hill, down and into this big old cavern of water, just trying to figure out what's going on. It's been very interesting and just circular. So I've been going around and around the same track and trying to figure out why I'm not coming up with a different result, which is why I finally did something different,
I
which
love that.
what we're here for, I guess.
Yeah, mine would be like I was thinking about it. It would either be Mr. Toad's Wild Ride, but then I was really thinking about it, probably Pirates of the Caribbean, because I love the saying in front of Pirates of the Caribbean, which says, uh, I forget the saying again. It's like, all ye who enter here is like,
Beware. Yeah.
it's like leave your souls at the door,
Yeah.
basically. Or all ye who enter here, leave your hopes at the door. Like, it's just like kind of you're going into hell, which that comes from Dante, and that's what is the health. I mean,
Yeah.
I told you I've been in healthcare for 30 years now, and it's been kind of the same. I don't think it's gotten better. I almost don't think it's gotten worse. I've seen it as kind of the same. I mean, I've had a lot of crazy experiences. Like I actually worked at Disneyland as a nurse, which was interesting. But I've worked with a serial killer and so many weird things. But let's talk about you. So tell us about yourself.
Well, I graduated in '99, so I wasn't that far behind you. I ended up um, getting fired from my first job as a nurse. Actually, I uh, I had the sensation that nursing was like other professions that I'd been in, where you go to your boss and you tell them there's a problem, and they just fix the problem, and everybody's better, the job's better, and you move on. Well, that was not the case, and so I kept going back to them. Hey, we just fixed this. Everybody's productivity will be better. The job will be better. Let's just do that. And they didn't like that. So I made three of my bosses cry and quit, and then they finally fired me. And so I was like, what am I going to do? And I was like, we got to work. And I was like, okay. So I did agency nursing. And so I got fired on Wednesday and I started doing agency nursing that Friday. And it's the greatest thing that ever happened to me. It made me actually love nursing again because I was hating it up to that point. They were mandating overtime, mandatory overtime, which of course, as you know, is illegal. They can't do that, but they tell us that they can, so people do it anyways. And I had a real problem with that because the our bosses weren't willing to work overtime, but they were forcing us to. And their excuses, well, I got kids. I'm like, well, I got kids too, man. This is so got frustrated with that. And then, so agency nursing was great because you got paid way more, got to do the same thing, didn't have to deal with the politics, and nobody messed with you because it wasn't in your contract. You didn't have to do it, which is really, 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 really eye opening to me as well. It's when I started really learning about contracts and I actually worked on a tele floor as a charge nurse, and they, I told them part of my contract is I either charge or I take patients. I don't do both. I had specifically written into my contract. And one of the house supervisors had been on vacation the first couple of weeks I was there, and she came back and they went to the pre-staff meeting or whatever and tried to get me to do that. And the nurse who was in charge on day shift, because I was doing nights at the time, told them I wouldn't do it. So she called me and said, well, John, they tell me you're not going to do that, but you're going to come in and do this. I said, no, ma'am, I'm not. I'm sorry. Like, you have two options. Either I'll come in, or three options. I'll either come in and I'll charge, I'll come in and I'll take patients, or I'll stay here and you can just pay me and I'll stay at my hotel for the night. And she got irate and said, well, I don't know what's in your contract, but you're going to come in and do. I'm like, no, the reason I'm not is because you don't know what's in my contract. well, I'm going to call the administrator and we're going to look and we're going to call you back and you're going to do what I say. Well, of course, they called me back a few minutes later and like administrator calls and says, well, we'd really like you to come in and charge and take patients. Like, I don't do that. So you got your choice. You can either, I'll either charge or I'll take patients, but I won't do both. Or your third option is I'll just stay here and you can pay me anyways because I'm available and you're not giving me an adequate assignment. They said, well, no, just come up here and we'll sort it out. And wouldn't you know it, they found another nurse somewhere. Unbelievable, right? Unbelievable what happens when they're
Right.
forced with breach of contract. So that taught me a lot about contracts. And I also do actually help nurse practitioners with contract negotiations now, which is a fun thing to do, go through contracts and try and teach them how to maximize the amount they can get from contracts and how to get bonuses and all that kind of stuff, which is fun. But anyways, so I was doing that, and then I got into an ER and was again another contract issue. When I got to the ER, I had specifically stated in my contract because this ER did 8-hour shifts at the time. I don't like doing 8-hour shifts. I want to do 12 so I
Yeah.
can do them in 3 days and get out. So I had them specifically state in my contract that I would only do 12-hour shifts. Any scheduled shift less than 12 hours, I'd be paid for a full 12 hours. So the first schedule comes out and has me working 5/8 each week.
Ugh. Yeah.
So me, I'm thinking, ching, 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 that's a lot of overtime. But then I thought, well, I should probably say something because they probably don't know.
Hmm.
And the interesting thing is the nurses at this particular ER had been trying to get them to switch to 12-hour shifts for a long time. And for some reason, administration wouldn't do it. And as you know, if you work 12s instead of 8s, it requires less nurses to cover the unit. So it didn't make any sense to me. But anyways, the scheduler comes up to me and I said, well, if I work this, I'm gonna get a lot of overtime. She said, no, you're not. It's 40 hours. I'm like, I know, but my contract says if I schedule me less than 12 and I work less than 12, I still get paid for a full 12. So
Hmm.
you need to be aware of that. And she's like, no, that's not right. It's just not gonna happen. I'm like, well, probably should read the contract. So again, they went to administration and came back, and sure enough, the whole unit was switched to 12-hour shifts after that. It was unbelievable. And from thenceforth, they were 12-hour
Wow.
shifts.
You're
And the
like the
nurses all loved it.
changeling.
Yeah,
You're
well,
like the
it wasn't
change agent.
intentional, but what happens when people that get excited about getting a contract and don't read the terms, and then they end up finding terms that they didn't necessarily know they wanted or didn't necessarily agree to or didn't know anything about and didn't understand how to read a contract to figure out exactly what was going on. So it actually worked out in my favor. And I worked there probably 3 years. And while I was working there, we had PA students rotate through, and I thought when the docs would ask them questions, they were pimping them, and I thought, man, I know answers to all of these questions. And I was, I guess, 3 years, 4 years out of, or 3 years out of, I guess, I don't know, 3 or 4 years out of nursing school, and I was already making probably the top 90th percentile of what I'd ever be able to make as a nurse. So I didn't see a lot of growth opportunities there. So I thought, well, I'm gonna go to PA school. And so one of my friends says, well, why don't you be a nurse practitioner? And I was like, well, what is that? I didn't know what it was. We didn't
Mhm.
have any. There was actually, rephrase, there was one in our town at that time. Town of
Wow.
100,000 people, we had one. Well, I mean, this is 2000-ish. There's just not very many
Right.
nurse practitioners back then, and I didn't even know what it was. And they're like, "Well, it's kind of like a PA." I was like, "Okay, well, I'll apply to both, and whichever I get into first wins, right?" And so I got in NP school first, and that's what I ended up doing. So uh, I did a lot of stuff: ER, family practice, urgent care, associate professor. I critical access, hospitalist stuff, and emergency medicine is my love, though. That's where I'm at now, and that's where I've done most of the majority of my practice. And I've volunteered on. I worked with the American Association of Nurse Practitioners on one of their education committees. Sat on that after I started becoming a problem on online. They got me in
You
there.
sound like me. So
So yeah, been all over. It's very very similar. It's interesting
yeah, well,
because
becoming a problem,
yeah.
that's what it is. I've gotten kicked out of organizations and stuff. So, I mean, people they don't like to hear the truth. I
No,
guess that's what
and
it is.
well, the part of the problem is what's the truth, right? So when you look, and the problem is academics only understand literature, right? If it's not in the literature, then it's not true, or it doesn't happen, or it didn't happen, or can't happen if it's not published. The problem is if you look at the literature and you try and publish in any NP journal, if there's anything remotely that they could consider negative towards full practice authority, it won't be published. So are we truly doing ourselves a service by not publishing the truth? I don't think so. And my contention is, of course, I mean, if you've read my paper, that it's we are nowhere near the amount of education we need to be, and it needs to change dramatically. But you also look at the difference in education styles from when we went to school versus how they're training them now, and the vast difference in experience of nurses that are going through now, that as opposed to 20 years ago. And there was a survey in 2006, which is close to when we both graduated, that 60% of the nurses going through had 17 plus years of experience that were going back to NP school.
Right. Before, like when I went into MP school, UCLA was wanting between 5 and 10 years,
Mhm.
and I felt that I really needed those 10 years in the nursing world to be strong enough to go in. And as a registry nurse, I had worked at so many places. I felt very confident going in, where there were colleagues of mine that went in who didn't even have any pediatric experience. And so it was kind of even starting at that time. And they were really struggling. And also, like, I worked at a school in 2014 where this is really interesting. The way the school started was they were getting doctors from other countries who, I guess, couldn't fulfill their residency here, because you have to do a residency for a
Sure.
couple of years and then you have to sit for the boards and stuff.
Mhm.
So I guess they were trying to bypass that. So they were putting them through this NP program. It was an 18-month program. Mind you, they had no nursing experience, no
Sure.
nursing education, nothing. So they were putting them through this NP program and then testing them. Okay. So after they did that, and I guess because they didn't pay for the program, they needed to come back and be educators. So now here you go. So you have these people who have no nursing experience. They're doctors in other countries. You throw them into this program, you have them pass the exam so they get certified, and now they're teaching classes. So do you think that they're really good teacher? How do you think?
No, probably not.
Exactly. They were terrible. So I come in, and I was just like, what is going on here? And they were very hush hush about that part. I had to figure it out. And so it was just weird. So this school was in Compton. Okay.
Mhm.
And it was predominantly African American. And it was cool. It was a brand new school. It was a great model. I loved it. They had a great simulation center, which was brand spanking new back then. So they had these doctors who mostly were Filipino that became nurse practitioners, and now they were educators. And then there was me. So this was, so you have Filipino, African American, and I'm literally the only white person there. And so I kept getting asked, like, do you feel comfortable working here, like by other teachers? And I was just like, why? I was I live in Los Angeles my whole entire life. It's one of the most diverse cities
And
ever.
one of the biggest melting pots, secondary to
Yeah.
New York and Los Angeles, very melting pot cities for sure.
Yeah. And I speak Spanish and I speak Italian and English. I was just like, I don't understand what you're talking about. So they had zero clinical placement. So in pediatrics, they were placing the students because I was teaching NP classes, and I was also teaching like the regular. So they had a mechan. So it was a bachelor's to master's. So you had to have your bachelor's in something.
Right.
So it didn't matter. It didn't have to be healthcare. So you had to have your bachelor's in something. You came into this program. It was 18 months, the same. You got your RN and you got your master's degree,
And you got
right?
your
And
NP, right? Yeah.
and then eventually they added on the NP. So in another 18 months, you got your NP, right? So that's how they worked this program. These people would fail. It was hard. I mean, they just couldn't, they were stumbling, they were bumbling. I mean, I would take them to an elementary school to do their clinical placements, so I had to be very creative in stuff, and they had no hospital contact at all because they couldn't get that placement for them. It was just a
Jeez.
mess. and there was so much like chaos in this school. The students even walked out at one point. It was super expensive. It was like over 100 grand to go there.
Oh,
You
geez, of
know,
course.
and it was just like, what is going on here? I mean, my takeaway is that the dean was trying to start like a nurse media center, which I thought was a brilliant idea. Brilliant. Like she was so ahead of it, but she just couldn't put it together.
Yeah,
So she gave it to me, and the students had done like a healthcare film festival thing. Like they had made some movies, and it
sure.
was just a last minute thing because the dean's sister was part of one of the Hollywood studios, right, at the time. So they were having this film festival, and she just was adamant that we needed to be there. So that was a positive for me because it really pushed me. I already had done some stuff, like some stage shows, but it really pushed me forward into starting my own nurse media stuff, which I'm now like rebranding and really trying to push forward even more. So that was my takeaway. I was like, okay. And I only lasted there less than a year and I had to leave. It was just too chaotic. But then the program that they started to do at that school is they got together with UCLA and they started a PhD program for these students,
Of
really
course.
feeding their ego. And they're like, okay, if you give us more money, you get your PhD. And it was in geriatrics, it was Gero, right? And okay, then you can come teach at UCLA. Okay, how is somebody with no nursing experience supposed to teach? And I would tell my students, I go, I think it's a con job. I go, I wouldn't do it because I mean, I don't want to take classes from someone who's never had any nursing experience. Would you?
Well, yeah, the problem is, and this is not saying that it's a detriment to individuals because they're doing what they're trained, right? Or what they're being told is good.
Exactly.
And what they're told is, and the problem is if you're told, you're told, hey, you're good, you're smart. It's the same thing they're teaching nurse practitioner students today is, hey, you're exceptional. You're able to practice independently upon graduation. You don't need supervision. You don't need anybody to lean on. We've got you trained to where you can practice independently upon graduation. And then when they graduate, they realize they haven't been properly trained. They start seeking additional education, which is why our fellowship slash residency, whatever you want to call them, programs
Yeah.
have exploded, even for family practice, even for pediatrics, everything. They're exploding right now because nurse practitioners are getting out and they get done and they start practicing and they cry themselves to sleep at night. It's
Yeah.
horrible. These people are going in, they're not trained. And then, so, when we first started, when we went through, the reason that the limited number of clinical hours was there is because we were supposed to have all this nursing clinical experience,
Exactly.
right?
Right.
And if you look at our time frame, you'd been what, 5 years, right? 5 years before you went back,
I
something like
was
that.
almost 10 years. Almost
Almost
10
10 years.
years. Yeah.
I
Mhm.
graduated in 99 and I graduated from NP in 2005. So
Mhm.
7 ish years I'd been
Yeah.
working as a nurse and tons of experience working all the ICUs and ER and all that
Yeah.
stuff. But um, you you take that versus somebody who's going straight through and doesn't have any experience taking care of sick people, doesn't have any experience seeing patients, then
Managing clinics,
not
being on your
anything.
own
Don't
and
have anything.
managing a
And then
team and
you give
stuff.
them 500 hours of training, which is where we're at, and that's what all you need to graduate. And that's all you need to practice on your own independently. I'm like, come on, man. We can't say that if you take an experienced nurse and add 500 hours, that equals nurse practitioner, and then turn around and say, well, if you take anybody and add 500 hours, that makes nurse practitioner. It doesn't make any sense to me. It doesn't make any sense at all. And that's I think doing what the end result is what's happened is we're devaluing our profession.
Yep,
We're
for
putting out
sure.
people who are not prepared. And the end result is the literature showing that our lawsuits are going up.
Mhm.
The amount of payouts of the let's say the value of the payouts are going up. So we're getting sued more frequently, and we're having to pay out more because we're not prepared. And man, we got to do something because this is
For
not
sure.
working out, not working out, not working out. And then you want to turn around and say any nurse practitioner can work independently upon graduation is what our professional organizations are saying. And I look at that and no, I don't think so, man. I mean, I've got students who come to me who've never cracked a book, who have never never, I mean, and I mean, never cracked a book. They don't know the first thing about patho. They don't know the first thing about pharmacology. They don't know how to assess people, and they're graduating in a month.
Right.
And I'm
For
like,
sure.
what
I've had
the
those people.
what's going on? And then you fail them in their clinical, and the school passes them anyways.
Yes, I've had that. I've had that where I've
What?
taught. Yes,
Kind
I've
of
had
crazy.
yeah, I've had that. They just pass them through,
Yeah,
so you go
and
ahead and fail this person. You're the
one
bad guy
one of
for
the
failing
instructors
them.
goes, hey, sorry, one of the instructors goes, hey, well, we can't fail them. The school won't let us fail anybody
Right.
because they're afraid they're going to get sued if
Yep.
we fail them. So we're not allowed to fail anybody. I'm like, well, then are you really an place of a higher education if you're not allowed to fail somebody? I
Right.
would argue that you're not, because if the person's not able to jump through the appropriate hoops and get the appropriate education in order to pass, in order to graduate, then is your diploma worth the paper it's printed on? I would argue
Right.
it's not, and any from that school would no longer be. That's kind of the way my thought is on that. And I think we're significantly, I think the other problem is our scope of practice is confusing as all get out. I mean, you get, like, I'm family trained, right? And I work in the emergency department. So what happens is, let's say I'm very good at what I do. Let's just pretend for a world of pretend that I'm very, very good at what I do. And let's pretend that you're family trained as well. And or let's do it the other way. Let's do that. You're very, very well trained family nurse practitioner working in the ER. And we have a doc who's working there, and he sees that you're a family nurse practitioner. And then I come and apply. I'm a new grad, family nurse practitioner who wants to work in the ER. And he goes, well, you're exceptional at what you do. You have the credentials F&P. This person has the credentials F&P. They should be able to do what you do. So we're just going to hire them, and we're going to put them in there. Right.
Right.
And that's what's happening. And we're firing so many because they're just not trained. And so what the end result of what's happening is, the businesses are no longer wanting to hire new grads, right? I don't know if you've
Right.
seen this, right? So they're no longer wanting to hire new grads. There's some that have put out specific requirements in their advertisements that they won't hire from specific schools because they care about their patients. What? Oh
Really?
yeah. Oh yeah. Oh yeah.
Wow.
That's going on too.
That's very
And
interesting.
other thing
Yeah.
that's happening is they're requiring training upon hiring before they let you practice independently. And this even happened in the VA, which recently said all nurse practitioners can practice independently. And then they went a year after that happened. They're like, whoa, 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 let's do this. Let's make sure that we have a residency for our people that come in, so they're trained properly, our inexperienced people, before we let them go. So that tells me we don't think we're trained well enough. And then we have the new standards coming out, which is increasing the clinical hours from 500 to 750, which shows the academics even realize that there's not enough clinical training, but they're not willing to say that it's not enough. We know it's not enough, but we think adding 250 will be enough, but no literature, no, zero literature studying this at all. None, not one penny anywhere, not one
Yeah.
drop, because
Probably
they won't
because it
publish
doesn't
it.
make any right. They won't publish it. Doesn't
They
make
won't
any,
publish
it
it. They
doesn't
won't
make them
study it.
money.
Nope.
Exactly.
Nope. They won't study it. So there's no incentive for them to actually figure out what it takes. So when I got involved in this because of the lack of training with a bunch of other guys, and we set up an organization that was we shut down shortly after because some of the other credentialed organizations didn't want us around. So we shut it down for a while, and considering starting one again to try and
Well,
get
here's the
this.
thing, what we were talking about before. So I went to my pediatric nurse practitioner, and I'm just going to say it because everybody needs to know it. It's called Nap, right? So I was
Mhm.
there. It was in Denver. Something fell off. Usually, it's pretty expensive, $750 to attend for 3 days, 3 or 4 days, whatever it is, plus hotel, plus
Sure.
airfare. So you're looking at almost 2 grand. Plus,
Yeah,
I took
chewing up your
extra
CME money.
classes.
Yeah.
Yeah. So that you could take a very nice vacation for that amount, and I pay out of pocket myself because I'm an independent provider. Many of the other nurse practitioners that were there, they either get their hospitals to pay for it, their employer,
CME reimbursement. Yeah.
right. So for their CME reimbursement. So when I went, something just felt off. It just felt kind of much lower level than other years, And a lot of people from California that I know didn't come. And I thought that was a red flag number one, because they always go,
Yeah,
So I'm like, I'm curious to see why they're not here, Probably because of the price, or their hospital no longer pays for CMEs, which I think that's the kicker. They only give them like
sure.
$500 or whatever. So the other thing was, I started to look at who the CEO of NapNap was, who's in charge of this organization, right? And so this one guy popped up, and he had been in charge of the organization since 2012. And all his experience was he had sat on a lot of boards. Like, he was just I guess, a businessman. I don't even know
Mhm.
what his degree is in. He's an older gentleman. And so I think his work was mostly in philanthropy and helping people uh raise money. Like, he worked for a private wealthy family. They had a nonprofit, so he sat on their board and he helped them raise funds. So that's all his experience was. He's not a doctor, he's not a nurse practitioner, doesn't have any healthcare experience, right? Nothing.
Oh,
So,
hold on. NAP stands for National Association.
National Association of Pediatric Nurse
That's
Practitioners.
what I thought. Just making sure. Okay.
Yeah, so I had never looked into it. I mean, I've been involved with this organization for almost 20 years now, and I never thought to look into it. And so I was telling people, do you know they're making about $1 million this week? Do you know the CEO, he wears fancy shoes. He has no healthcare experience, but yet everybody on the board has a doctorate. Everybody giving a lecture today has a doctorate, and they're maybe paying them $100 plus maybe free entry, or if that, to
Sure.
the conference, And so that's all they're getting out of it. But yet, if you want to help promote the organization, it's like they're like, hey, come write these CEs for us, create 45 slides, on a PowerPoint. And I'm just like, that's a lot of work. Speakers get paid between $1,500 and $5,000 at conferences. Okay. And it's like, these people are literally working for free. They're
Yeah.
literally feeding their egos. Oh, hey, come be the president, come run, Plus, they have the little chapters in like, they have an LA chapter and an OC chapter. I myself was once the president. So then they put me as the vice president, because the other girl had more research stuff behind
Yeah.
her. And it was like, I should have said no. I was like, I was too busy at that time. So eventually I ended up getting kicked out because of my viewpoints and stuff, and a blog that I had written about the truth. Right. So I was like, fine, kick me out. I don't care. I'm not getting paid to be here. It's
I'm,
an,
I'm well, I'm well, I'm well aware of
yeah, it's
academic
6 hours
response to
out of
things
my
they don't like.
Saturday. Okay. 6 hours out of my personal Saturday time
Uh,
to make this man rich. So
yeah.
and so people are like, how did you figure that out? Like, why are you thinking that way? And I go, well, one day I picked up the Epoch Times at 7-Eleven, and on the front page there was this GI conference, and it was a journalist who wrote about it. She had gone to the conference and interviewed all these people, and she found out that they were making about $1 million, mostly from the pharmaceutical people, you know? And so I started thinking, well, I wonder how NapNap is run. And when I felt the energy was just off, I started to investigate.
Yeah.
And people were like, "Oh yeah, that guy is here. He's here. He actually spoke." And I go, "I must have missed that session. I don't know. I guess he was speaking in the little sessions to the people, but is no one raising their hand and saying, I mean, we're getting bashed in California. A nurse got sued because she was saying she was a doctor, and
Yeah.
she has her DNP, her doctorate of
Yeah.
nursing practice.
Yeah. I
What
got a
are the
problem with that though, too. I mean, that's a
so what's your problem with that?
well, so here's the thing. I have no problem with somebody using the title doctor in a non-clinical setting.
Mhm.
If you have a clinical doctorate in a clinical setting is okay, but there's no clinical doctorate in nursing. So the DNP is a
It's like a PhD.
well,
It's
it's an interpretive research doctorate. So the PhD is a research doctorate, and the DNP is an interpretive research doctorate. And many, even in our profession, confuse it as a clinical doctorate. But a clinical doctorate requires you to have some form of clinical training and that prepares you for licensure. And the DNP does not do that. As you're aware, any nurse can get a DNP. You do not
right.
have to have advanced training in order to get a DNP. Although in the DNP guidelines, it says you get advanced practice training. Well, in order to get around that, advanced practice is also considered administration and informatics. Although
Interesting.
when you look at the what is it, oh my goodness gracious, my brain left me for a second. Uh, the literature that came out, that the nursing put out, the consensus model lists advanced practice as only CRNAs, nurse practitioners, midwives, and clinical nurse specialists, right? However, if that was the case, then only those four would be able to get a DNP, but it's not, because the DNP has advanced practice in it, and you can get DNP in leadership and in informatics and in administration, right? And you can get a DNP associated with a nurse practitioner. They're not the same. The training is not the same. So to me, utilizing the title doctor in a clinical setting, because in a clinical setting, it is assumed when you say, if I said, hey, I'm Dr. Canion, you would automatically assume that I'm a physician, right?
Exactly. Right.
Or have some clinical role associated with that. And nurses will argue, well, no, ours is a practice doctorate, similar to a pharmacy, the PharmD, or similar to the DPT, the Doctor of Physical Therapy. But there's a difference. The difference is the D in every DPT is a pharmacist, or every DPT is a physical therapist and can practice as a physical therapist and can sit for licensure as a physical therapist. Every PharmD is a pharmacist, can sit for licensure, can practice as a pharmacist. Every DNP can sit for nothing and gets no clinical training, right? That's the difference. So that's
That's
why
very,
in
yeah,
clinical
that's
setting,
really
I'm cool
interesting.
with all those other ones, even chiropractor, I think they're DC. Is that right? I can't remember what they're, is
Doctorate of
that
chiropractic.
right?
Yeah.
All of them can practice and sit for licensure as a chiropractor, doctor of chiropractic. None of us getting a DNP allows you to sit for nothing. It allows no clinical training. Our clinical training is done at the master's level, even if you get the NP and the doctorate at the same time. That's why I think it's not okay. And why that's a good example of us overstepping our bounds and utilizing the title improperly. Because when I'm in a clinical setting, I'm working as a nurse practitioner, right?
Right.
I'm not in a clinical setting as a doctor of nursing practice, because a doctor of nursing practice is an academic title utilized for an academic role or an administrative role. If I'm in an administrative setting in the hospital, for instance, if I'm in the hospital and I'm in an administrative setting, I'm in a meeting at, oh, let's say I'm in med exec meeting or something, sure, that's
Mhm.
okay, as long as everybody in that room understands that that title is for my administrative role and not for a clinical role. That's where it gets confusing, even using it in meetings in the clinical setting. However, that being said, if I'm in my instructor role as a professor and I'm teaching RN students or whatnot, or even NP students, and they call me Dr. Canion, and then that's fine. That's that. Oh,
Right. I hear
okay, that's
you.
fine. But as long as we're not doing it in front of patients and attempting to mislead the patient, because to me, in that instance, you are attempting to mislead them, and if you're doing that, to me, that's unethical. Right? Do you see what you follow me
Yeah.
on that? I think that's unethical.
I totally get it. I mean, I've thought the role myself was a total mind fuck for people who love egoic things. End of story.
Well, but it
And it's
started out
very
to
true.
truly be a clinical doctorate. That was the goal. And
Hmm.
that's why they eliminated oh gosh, let me see if I can remember it. The ND, the DN, the DNS, the DNSC, all of those, I can't remember them all, but I'm trying.
Yeah.
All of those were eliminated to make room for the DNP. And as nurses, we had an opportunity to really, really push the envelope and make our training top notch. And
Right.
we had that opportunity and we failed. And the reason we failed, well, at that time, I don't know if you know the story on this all that much. At that time, the number of PhDs was plummeting in nursing,
Right. Right.
absolutely
Oh
hitting
yeah. I
rock bottom, which
remember.
is why they were pushing the DNP so hard, because they
Yeah.
wanted doctorally prepared nurses, which great. I'm 100% on board. And they said it's going to be clinical. I'm like, great. We need it. We need another 1,000 hours of training. Well, not quite enough, but we'll take it. It's better than
Right.
500. That puts us at 1500.
Sure.
It's closer to 2000, which would our counterparts get in their master's program. Okay, but we all have nursing experience, so a little bit less cool, right? We all have nursing experience, right? That's why a
Right.
little
Right.
less is
It's
good,
like
right?
wink, wink.
Right, right. So, and then we get this, and then when the DNP comes out, it's not clinical. It's
Right.
not additional training. There is no helpful clinical, nothing that helps you clinically. And what's interesting is there's a complete dearth of data in the literature on this. There's no evidence that the DNP is beneficial to a clinician at all. None. Zero, zilch, nada.
Right. It's
Only
true.
thing literature shows is that the DNPs pass the NP boards at a slightly higher rate, which may or may not be statistically significant depending upon how you interpret that particular paper. So a little bit higher. So, but again, you would assume a doctorally prepared person would be a little bit better student as well. So there's a little bit of assumption there. So I'm not sure if you took PhD prepared NPs versus DNP prepared NPs, if they would pass at a different rate, because there's not that many
No,
NPs getting their PhD as
it
well.
takes too long. I
Yeah, it
mean,
takes too long. And if you go down that path, you're going down a path of academics, which
exactly.
very few like to do, and a path of research, which very few like to do, which is understandable. And unfortunately, our academic world doesn't pay well.
Right.
Which
So
unfortunate
true.
for our academic counterparts who are doing God's work most of the time. But the problem, end result of this is we're not able to see what's actually going on because of this. So we're not
So
actually see
true.
what's happening. And when we can't publish data that shows what's going on and nobody's studying it appropriately, we end up with going down a path where we feel like we're practicing independently and we're ready to go. And I actually give lectures at universities towards the end prior to graduation, and I lovingly call it shit you should know before you graduate.
I love it.
That's not the official
You should
title, of
publish a
course,
book.
but
That's the title of your book. You should
that's
know before you graduate.
so. And interestingly enough, I give this lecture, and it's all day lecture, about an 8 hour lecture. It's a lot of content. And the morning lecture lasts from 8 to about noon, and then we break for lunch, and then we come back and do 3 to 4 hours in the afternoon with a big long question and answer session at the end. And because I'm a very interactive educator, teach, I do not lecture very well. I interact as I lecture, so it makes it a little bit more less
And
likely you're going
that's
to fall
how it
asleep.
should be, I think it's like the thing about someone sitting there and just talking, 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 and you're just like, wait a minute, that's not right. I mean, I found a lot of those when I went to
I,
Nap Nap,
I
and
have
I'm
an,
here on my phone, like Googling and researching. I was like, she's wrong,
I
you
give I
know?
give I give an intentional misleading evidence during my lecture to see if anybody catches it,
Right.
and then I ask them questions about specific errors to see if people catch it, and sometimes they do, and that leads to fun conversations, right?
Exactly. And that's how it
But
should be
yeah,
nowadays. I mean, it
so
should be like a
and
tennis
there's
match.
so much literature at
Yeah.
the tip of everyone's hand. So it's easy to have those kinds of things if you have interactive students. But I digress. So I got through to the first one of these, and I got to lunchtime, and the students stopped me and they said, "We have learned more in these first 4 hours than we have learned in our entire 2 years."
I love it.
That's horrible. I mean, it's great.
It's great for
That's
you,
no, I mean
but
it's
horrible
good that
for
they're
them.
learning, but
Yeah.
it's horrible that that they don't already know most of this stuff. Having a little bit, yeah, maybe. But when I came back at the end of the day, their instructor had 7 pages of notes written down and was still scrawling at the end of my lecture. And that's great that she wants to learn and get ahead, but she should already know this stuff if she's going to be teaching it, you know. And then I had
So
a
true.
student come to me who was a F&P, acute care NP, going back for their ENP, who
What's
also
an
already had their
ENP? What's an
DNP.
ENP?
ENP is the emergency nurse practitioner
Oh,
certification.
okay.
That's
Okay.
new,
Uh-huh.
right? So that's a new thing out in the last, I don't know, 5, 6, 7 years. I can't remember when it first came out.
Hmm.
And it's a new additional certification. So she had her family nurse practitioner, was a DNP, acute care NP, and was going back for her ENP. A lot of
She likes
initials there.
school. Yeah, she likes school.
So she came to me and couldn't do a proper physical exam,
Wow.
did not know the antibiotic classes and how they worked. And she's teaching pharmacology at an
Wow.
NP program. Okay. So I'm just absolutely floored and flabbergasted
It's
that
the
you're
blind leading the
teaching
blind.
a
Yeah.
pharmacology course. And I said, well, how are you teaching this course? She goes, well, it's easy. They have to write 3 papers. Are there any tests? No exams.
What? Oh, wow. It's
So they
scary.
just write 3 papers and do discussion boards. And that's your pharmacology class?
Is she teaching
Huh.
online? Is it some
Oh
online
yeah, it
school?
was online. It
Probably,
was an
for
online,
sure.
it was online
Yeah.
school. But and you just get flabbergasted and floored by these things, and then you end up online in these NP groups, and you see the questions that they write in there, and I just, I want to say, and sometimes I do, sometimes I can't control my little commenting fingers, and I'm just like,
Me too.
how did you not learn this in school?
You're right.
How do you not know this already? I mean, one of them asked if they could order a mammogram the other day. A family nurse practitioner. Well, are we allowed to order that?
How do you
Yes.
not know that? Yeah,
Yeah,
it's part of
yes.
your
How do you how are you practicing and do not know how I just and this
yeah,
is part of your
that's
training. You should know the
scary.
answer to this question. But so my contention now is that we aren't well enough trained. We should not be letting anybody have independent practice until our education is revamped. 100%. We're not enough, not even close. I think maybe 20 years ago we were doing it and it was sufficient. But
Yeah.
now I
No,
think
not
people
now,
are
not
being
with these new
successful
people.
in spite
No.
of their education instead of because of their education. I think we need to be placing students clinically. There's too many stories of students, one not getting placed, having to fall back and take it again, which means more money for the university. So university don't give a shit. And then you've got so many students who are going to clinicals, not actually learning anything, barely shadowing somebody, getting their hours signed off,
Right.
and so they don't learn anything. And then you've got people who are there's stories of paying for clinicals, of course. And then they go to the clinical site, and the person who utilizes them uses them as a nurse to work in the office, doesn't teach them anything, and then signs off their hours at the end.
Oh my God.
It literally uses them as a nurse in the office. You're just going to work as a nurse. You're going to take vital signs. You're going to give shots. You're going to do whatever I need. We need to move patients. This is what you're going to do. And then at the end,
A
signs
nightmare.
them off.
Wow.
So you've got somebody who has zero training, and then you get the academic side where the academician says, hey, this is a learn as you go. You're supposed to be an adult learner. You're going to learn this content on your own. We're going to do discussion boards. There's going to be no tests. You're going to write papers. And then you're going to learn what you need to learn in a clinical setting for which you only have 500 hours, which you're just shadowing somebody and just literally doing nothing or working as a nurse. How are you
Yeah.
supposed to do that? Right? I don't get it. So I think we need to switch modes. Now you're a pediatric NP, so I want you to listen to what my plan is and then tell me what you
Okay,
think.
you
Okay.
tell me what your
Let's
plan
see.
is, and I'll tell
So
you what my plan
my
is.
my
Yeah.
my golden scenario is to have a base nurse practitioner, 2,000 hours at the master's levels, rotating through all areas of medicine. So you rotate through family practice, internal medicine, hospital medicine, emergency medicine, orthopedics, general
Yeah.
surgery, pediatrics, rotate through it all, psych. And then you're done at that point. You get your base NP where you can go out and practice and you can work whichever field. Now, part of that is you may go, hey, I don't like this adult shit.
Hmm.
I want to be a PDMP. So at that point, then you can go get your clinical doctorate where you spend 4,000 hours of education getting your specific NP in whatever area you choose. So if you want to be pediatric NP and you want to work in the outpatient setting, you get your pediatric NP. If you want to be a pediatric work in the inpatient setting, you can say a pediatric acute care, whatever you want to call it.
Sure.
I don't
Hmm.
know that our
Yeah. Yeah. Acute
nomenclature
care.
is great right now. Or you want to work in the ER, you go get an ER NP. You want to work in a family practice, you get a family practice. You want to work just adults, you get an internal medicine variant of an NP, and you spend 4,000 hours, and it is controlled by the academicians. So you have an academic control of clinical training. So that way, if I'm your professor, I know, hey, I'm going to send you, Ursula, I've got a student coming to you this month. She's a little slack on her ability to read and interpret films. So please, if you get any x-rays, please go over them with her and train her on those.
Right.
Right. So that way I actually have a little bit more interaction, a little more control over what's going on. So I have a little more strength. Or I can say, hey, you need to go spend 150 to 200 hours in radiology with the radiologist going over films, because I just don't
Sure.
think you're strong enough in that area. That way I have control over what's going on, and I make sure that you're growing and progressing. And when you get done, you're able to practice the first day. The
Yeah.
first day you're able to do the job to 100% instead of going home crying, thinking you're killing people. And our academics now use the term imposter syndrome. They
Oh,
throw that around a
yes.
lot. Say,
Oh,
well, it's
I
just
hate that.
imposter
Yeah.
syndrome.
No.
Well, is it? Is it imposter syndrome, or are we not training people appropriately?
Yeah,
What
it's
is
you're
it
not
truly?
training people. Why don't you feel comfortable enough? Sure. I mean, here's the thing. This is what happened to me once. So I took a break. Um, I was working at a children's hospital where we were not writing scripts, right? We would just
Mhm,
order Versed or albuterol treatments and stuff, but we were not
mhm.
writing for antibiotics and stuff like that. So I worked at that place for about 6 or 7 years. I left and I was just like, and then I went to work. I started doing some teaching and I worked for a pharmaceutical company. So I had a good block of time where I wasn't writing scripts,
Sure.
but my physical assessment skills were pretty spot on and strong. So I started working locums at a place and I told him right off the bat, I go, listen, I'm really strong with my physical assessments. You know, I'm weak with writing scripts. I go, I just need a little bit of help in doing this and then I should be right up on track again, you know. And they're like, sure, we'll help you, and I got the help. And within a couple, I barely took me like a week or two. I was on my own. I was like,
Yeah.
good. I just
And,
needed a refresher,
and
you know? But
that's
here's the thing.
reasonable.
Why aren't these students doing that? Why are they feeling that it's okay to go out and practice? Why don't they ask
Why?
for more training
Why?
or go
Why?
get that more training?
Because, well, some of them do, and that's why we've got the explosion in fellowships and residencies, where we've just absolutely exploded. Our numbers have gone just over the last 5 years.
Yeah.
Our residency training programs, I can't remember how much it's increased, but by a lot. I mean, we've
Yeah. There's a
done
lot
it
of them now.
significantly.
Sure.
And
Mhm.
that's part of that, is they're actually figuring out they don't know and they go for more training. But the other thing is, if you're in school the whole time and I'm sitting there and I go, hey, this isn't, we're training you. You're really good. You're smart. You know everything. If you pass boards, you can practice independently because we've trained you.
Oh my God.
And if you don't know, and I'm telling you that you know, then you assume that me, being the experienced educator that I am, would be able to tell you appropriately that you've been trained appropriately. Now, you're also assuming that I didn't just go through, get my RN, get my DNP, get my NP, get my DNP, and then start working as an academic, which does happen as well,
Right.
right? So you have people who've never actually practiced who are now educators,
Or who are now educators.
right?
Exactly. And that's
Which
a huge
I
pet
got no
peeve of
problem with
mine.
that. If somebody's an excellent educator, somebody can teach very well without being an excellent clinician. And I think there's excellent clinicians. I think there's excellent academicians. I don't think that those necessarily two combine very well, because I think if you're going to be excellent in the academic world, you have to study the academic side of things, and that takes away from your ability to study the clinical side of things. And you have to spend more time in the academic world. Vice versa,
But then with
if
me,
you're in the
I'm
academic,
huge
if you're
on,
in the clinical
yeah.
world, you spend all your time in the clinical world. You don't spend time in the academic world. And you don't know how to teach shit. So
Kind of sort of, but then it's like I like real world stories.
yeah,
It's like I want an instructor who's gonna really tell me, like for example, when I used to work for a pharmaceutical company, our best storyteller was the one who the cardiologist who would talk about his patients. He was the one who filled our steak dinners up. Right. He was the one who would bring in the audience because he told the best stories and he would talk about his patients and real experiences on how he would use this drug and everything. And he was a great storyteller,
yep.
you know.
And
So I think that that's huge, especially in nowadays where everybody their attention spans are like this much.
there are
I
some
mean,
people who are really, really good at both. But I think
yeah,
the ability to do that is very, very rare. And I
it's
think that
rare.
it's
It's
something
you're right. You're
that it's
correct.
just it's not most people can't keep a foot in both world and do it very well. Most
It's
people can't.
true.
But that's not to say that people aren't great at both or great at either, or just to mean that you're great at one means you're shit at the other. That's not what I'm saying, right? I mean, you can be a
Mhm.
great clinician and a great academician, but I think if you're if your focus is in one area, you tend to lose focus in the other area. So you could be an excellent clinician, but if you're spending all your time in academia, you're going to be a far better academician than you are a clinician. But you could be a far better clinician than an academician if you spend all your time over there. I don't think it's
Mhm.
definitely a
Yeah, but
wash kind
with
of thing.
doctors, with surgeons, they're associate professors. I
Yeah,
mean, immediately, like
practicing.
I know,
Yep.
for example, like at Children's Hospital LA, they have Keck USC. So
Mhm,
a lot of their surgeons, a lot of their physicians are also associate professors.
mhm.
So and they're giving lectures and teaching. So I mean, again, and I don't know how well of a professor they were. I worked with a neurologist who would give great lectures, but he was very shitty in clinic, in my opinion. In my opinion, like he was just full of he was just a
Yeah,
liar,
yeah,
you know, and
yeah,
that's a whole other
yeah,
podcast for another day. But
yeah.
yeah, but basically what I think needs to be done in the nurse practitioner world is we need a rebranding. I mean, because they've, you know, we really need a rebranding about who we are and what this profession is, especially nowadays, you know, especially with what's going on with all these online schools and people just going through
Best
with
way to start
that.
that's
Yeah.
revamp the education process.
Yeah.
I think if we revamped and went to what 6,000 hours of total training, then what would happen is by default everybody would go to get their doctorate. Everybody would.
Right.
I mean, if we had that, I would sign up tomorrow. Not because I feel like I need it, but because I think it's necessary to move the profession forward.
I think so too. I
And I
agree
think
with
that
you.
what would happen is instead of getting all these people out where we're having to fire people constantly and businesses are trying to find ways to train people as cheaply as possible in order to get in their money's worth instead of having to terminate and rehire and terminate and rehire, we would end up with a crop of students where the ground floor is not here, it's up here. So
Right.
then we can control what we're learning, we can control how much we're learning, and we can reevaluate. I think the other problem is nobody's evaluating our education appropriately.
No.
Nobody's going back
But
in. There's
who
no
is going to
studies where we go,
evaluate? I mean, is it the boards of registered nursing? Is it these
no,
organizations,
I think
these
there needs to be
associations? I mean, that are
I think
run
there needs
by
to be independent.
non-nurses?
Yeah, well, I mean, you can't really do that. But if academia can actually study this, if they would be willing to, the problem is they're not willing to because the goal of academia right now is independent practice. And unfortunately, the goal has moved from taking care of patients to independent practice. So I actually I've received some negative backlash from my academic friends on this paper that I published, as you can imagine.
Yeah,
And
I saw the comments on LinkedIn. People are like, "Why did you say that? You're belittling our practice." No, we are not the ones belittling the practice. The nursing schools are the one who
it's
are literally bastardizing
if
the
if
profession.
if you would defend the profession appropriately and train people appropriately, there would be nothing to bash,
Exactly.
right? And the problem is they yell at me for this. Is like, well, you're going to make it to where we can't get into independent practice. And I said, what? That's not the goal. The goal is to take care of patients appropriately. The goal is
Right.
when my dad goes into the clinic and sees a nurse practitioner, they don't miss. So he
Right.
ends up so my dad had a fall and
Mhm.
broke multiple ribs, multiple rib fractures, and went into urgent care. Urgent care took an X-ray, said you have some rib fractures and you have it looks like a developing pneumonia, which is obviously not a developing pneumonia with fall, it's pulmonary contusion. So over 65, multiple rib fractures, pulmonary contusion requires admission, hospitalization because the risk of mortality goes up 8% for every rib broken over 3, right?
Wow.
So yeah, it's pretty significant. So those require admission. So I told him you need to go to the ER, you need to get admitted, right? So he goes to the ER, sees another nurse practitioner. Nurse practitioner CTs his chest, says you have rib fractures, pulmonary contusion, but you're not hypoxic, you can go home. Sends him home.
Oh.
Despite my uh, vast complaint otherwise to him, right? So, and when I'm doing this, I'm sitting in an ER next to in a level 2 trauma center next to the trauma surgeon and my medical director in the ER. just absolutely flabbergasted,
Wow.
absolutely just flabbergasted. And no, you need to be admitted. And they're like, my dad's like, well, he was a nice guy. He said we could go home. My pain's better, you know. So they went home. Well, the radiologist missed a spleen lac also on his
Ugh,
CT. So,
wow.
a couple of days later, he's being life flighted to the trauma center. And now
Oh,
that may not have changed the end result of him getting life flighted to a trauma center. If he'd have stayed in the hospital, continued to have severe pain, likely it would have been evaluated by a surgeon, and likely they would have caught the mistake
for
instead of
sure.
him going home and potentially, I mean, thank God, nothing bad happened, but the end result of that is nothing. So my dad ended up being okay. And of course they don't want to sue because everybody was nice to them and all that stuff.
Right, right.
As you're aware, that's the number one thing that prevents lawsuits is people being
Is if
nice.
you're nice.
Yeah, if
Yes,
you're
yes,
nice,
I
you're not
hear
going to get
it all
sued.
the time, you know.
Yeah, be
I always
nice.
ask people, "Why do they like that one doctor or that one person?" "Oh, he's so nice to
Yep.
them." Meanwhile, you look and this person's, like, getting worse, and you're just like, "Ah," they won't
And
even question stuff. They're like, "But he said it was normal."
and then you get into this thing where you go, well, now, so this is how I practice, right? And we have nursing theories, right? The nursing theorist,
Mhm.
you remember all that stuff? Well, I came up with my
Yeah,
own
yeah.
nursing theory, right? So I have three pillars of practice, is what I call it. There's three
I love
legs
it.
to a stool. You're sitting on a stool. There's three legs. The first leg is the science of practice. That's what we all learn in school. That's knowing when to recognize a heart attack, understanding which hypertensive drug to use, understanding which diabetic medicine to use, all that. Okay. If you're
Mhm.
bad at that, that leg's going to break. You're going to fall because you can't sit on a
For
stool with
sure.
two legs, right? The second leg of that is the uh, art of practice. And as nurses, the vast majority of nurses are exceptionally good at the art of practice. That's knowing
Mhm.
when to go in and grab grandma's hand and talk to grandma and make sure she's doing okay, versus the one nurse we know who's a battle axe who is not good at that. Right? You all know that one. Right. I know you just
Right,
thought of one in your head. You just thought, oh,
right.
I know what he's talking about. So
For
we all have
sure.
that one. And then the third leg is the business side, right? And if we're unsuccessful at the business side, if we're not billing appropriately for what we're doing, we're not going to be able to keep our practice open. We can't keep our practice open. The community and our patients suffer, right? So
Right,
that's like, I kind of think of it this way. If you go into the tire shop and you get your tires changed, he's going to bill you for changing four tires,
right.
right? Not three, just because he feels bad for you, right? Not three because, oh, well, Jimmy's having a hard time. No, no, we still have to bill Jimmy for four tires, or the tire
Mhm.
shop's going to shut down and nobody's going to get new tires. So if we
Very
think
true.
about it from that perspective, we have to make sure that we bill appropriately, not billing inappropriately, but we bill for what we do, right? If you
Exactly.
do, if you tell people that they need to quit smoking, you bill for it. If you check their hypertension, you bill for it. You make sure you bill the appropriate levels. Nurse practitioners as a whole are really, really bad at billing. We
Yeah.
generally underbill significantly. Instead of billing 99215s, we bill 99213s. Instead of billing 99214s, we bill 99212s. Instead of these are office numbers for those that don't know, billing codes. One, two, three, four,
Mhm.
five is the
Sure.
severity five at the top, one at the bottom. One is zero, zero, one is when your nurse does something, two is view up and everything. So um, and we typically underbill, but you need to bill appropriately so that way, one, you get compensated appropriately for what you're doing, and two, so that way your business can thrive. If the business thrives, then you can take care of patients. If the business is
Sure.
unsuccessful, unless you're in an FQHC, right, which is a completely different ballgame, right? Or you're in an area that is not an FQHC but is funded by a um, grant or whatnot, right? If you're
Right.
one of those things where it's not quite as big a deal because you're really not billing anyways, then but you still want to document appropriately. And document appropriately is selecting the appropriate billing qualifier. So that way your um, FQHC or your grant money, people can see what we would be spending. So that way you can maybe get more grant money, maybe get your
Exactly.
FQHC more money, that kind of thing. So that's how you do those things. And people have to understand that. But that's kind of how I look at it. Is the three pillars of
Yeah.
practice. Now, if you look at that from that perspective, and we're all good at the art of practice, then we're less likely to be sued, right? So if
Mhm.
we're less likely to be sued because we're nice to patients and we have the art of practice, then it's hard to actually judge how we're doing as a profession. Although the literature came out and it shows we're being sued at higher rates and we're being sued for bigger payouts, which means we
Wow.
are making mistakes. And the other part of the problem is we cover for each other. And it's not intentional, right? It's not like I'm covering up some big dark secret that somebody did. No, but if somebody comes into the ER and they saw somebody as an outpatient, and the outpatient made an error, I don't go, hey, these guys messed up and they really shouldn't have done that. No, what I do is say, hey, we need to put you on a little bit stronger antibiotic, or hey, we need to put you in the hospital and fix this problem. It
Exactly.
got worse, right? I don't, because as a profession, you never ever call anybody out. That's 100% not the right thing to do. I'm not saying
Right.
to do that. So please, nobody think that. Not saying that, but we do that, and it's not an intentional thing. But if you come in and you have a problem, I'm just going to fix the problem.
Exactly.
And I may
Exactly.
recognize that, hey, this person had a little bit of a problem, but I'm not going to say anything the first time, the second time, third time, fourth time, fifth time.
Yeah,
we'll
once you see the
we'll
pattern,
sort it
you're
out,
just like,
and then
okay.
when it gets to be a bunch of times, then you start going, hey, we need to have a conversation about this person sending us in stuff,
Exactly.
right? And but I don't do that either. We go to the medical director, we go to the administrator, we let those types handle that thing, because unless that person, like, I've been had been in the administrative role in the ER before, where I've had to fire people, and I've had to have those conversations with outlying NPs and PAs and docs and et cetera. And that's never a fun conversation to have, but
Mhm.
you got to do what you got to do, and you have to take care of patients appropriately, which is what we're here for, man.
Exactly.
That's what we're here for at
Exactly.
the end of the day. We're here
Sure.
to take care of patients. And these one of these days they're gonna be taking care of me. And
Exactly.
up front, I go see a nurse practitioner right now, 100%.
Yeah, for sure.
But
For sure.
but I know him. I know where he went to school.
Exactly.
And if I get referred to somebody who I don't, the first thing I ask them is, where did you go to school?
Exactly. Oh, me
And
too. I
if they went to a school that's on my list, I don't continue
Yeah,
the
exactly.
visit.
I have my friends that I can go to who are
Mhm.
NPs,
Who I know very well,
who
who
I
I
know
know their
very well.
education.
I
I
know
understand that they're good at what they do. Yeah.
very true. But one time I did go to an NP. I think this was in 2019 before the pandemic. And it was like a clinic and a Target, one of those
Yeah.
shop.
Yeah.
Okay. I was like, this is so cool at a major, it was by a major organization. So I was like, oh, this is really cool. It was very high end, it was very modern. And I walked in, there was nobody there, and I needed a physical exam, you know. And I went in, I was like, "This is the coolest thing ever. I would totally work here." And she was just like, I go, "Gosh, and you're not busy. That's so cool." She goes, "I am busy. I have charts to do." Like, she's like, and I go, "Uh-oh, red flag number 1." So then
Yeah.
I go, "Oh, you look so familiar. Did you go to UCLA?" She's like, "No." And I go, "Well, where did you go to school?" Did not want to tell me. Did not wanna tell me. Red flag number 2. I go, "Did you go to someone," I was talking
Yeah.
to her, I go, "I swear to God, have I seen you somewhere?" And I kept doing that. She was getting more and more annoyed. She's like, "You don't know me." And I was just like, "I know, but I don't know." I go, "I'm an MP too. Let's connect." She just did not
Yeah.
wanna connect on that level, which shows me she was terrified,
Yeah.
because she went to some online school, you know? And didn't wanna tell me. That had
Yeah.
to be the case because she told me the name, and I was like, "Oh, I don't know what kind of school is that?" Well, like, "Where is that school at?" Because we are in California. I know all the top NP schools,
Hey,
you
and
know?
I'm okay with online training. Don't get me wrong. I don't think online per se is inappropriate, but it has to be done right. And the way we're doing it well
Exactly.
is not. I mean, if you're doing just discussion boards, you're not getting lectures. I had one nurse practitioner text me the other day, or send me an online message, because I'm kind of online in all the discussion boards.
Mhm.
And she said she went through school, never once had a lecture. All she did was discussion boards and papers. She got through, passed her tests, and now she doesn't feel like she's comfortable or safe practicing. She's
Wow.
like, how can I do this and practice and work and take care of patients safely and never have had a lecture,
Oh,
never have had a test, never had a test in her entire program? How are
wow.
we testing knowledge, man? I don't know.
Yeah.
Kind of stuff
Yeah.
just agitates the living hell out of me.
Yeah.
And I'm
So
like, I told her, she's like, what advice would you give me? I said, you need to go to a fellowship. You need to
yeah.
get trained. And it's evident, and I don't mean this in a bad way, but it's evident you haven't been trained, and you got to get trained. And even when I got out, umpteen billion years ago, back when we walked uphill both ways through the snow, uh, when
Yeah.
I got out, the first thing the guys did when I worked my first shift in the ER is they grabbed Tentinelli's, which is the emergency medicine Bible, put it on my desk, and said, "You're going to see every patient, and we're going to go every single patient with you."
Oh.
And
Yeah.
that was my training. And before that, and so my F&P training was a little bit different than most now that I understand that. I had 750 hours in the ER alone before I graduated.
Wow.
So yeah. So and I had 400 hours in inpatient medicine, and I had another, 1,200 outpatient with between family practice and all the other stuff I did because we were had to work critical access back then.
Mhm.
So that was part of our training. I don't know if you guys had to do that, do the PD side, but the family nurse practitioner side, our goal was to work critical access. So we had to have a rotation in a critical access setting where you went out to the critical access area, you stayed the night, you were on
Wow.
call while the doc was on call. So if you had to go to the ER, you had to go to the ER. If you had to put patients in the hospital, you had to put patients in the hospital. If you
That's
had to do
awesome.
procedures in the ER, you had to do procedures in the ER. So it was
Mhm.
enlightening as to what being in a critical access area is actually like, where you actually have to do everything because you're the
Right.
only person there. So you have to do everything. So it was actually eye-opening, and I actually enjoyed it, which is why I did critical access medicine for a little while. But the problem is you're supposed to get student loan reimbursement if you work in a critical access area. Doesn't happen. Doesn't happen as much as they say it does. Oh, if you do it, we'll get no, doesn't happen. So just be aware of that. If you want student loan reimbursement, make sure they put it in your contract. Okay.
Right, for
The
sure.
federal
That's
government
another
is
thing.
not good for that. There's
Sure.
limited amount of funds that they have, and once the funds are dried up, that's all there is for that year. So,
Cool. So what's next, John? So you
oof,
wrote your article, which we'll put a link on this episode so people can read it. And so how do people like join this crusade?
well,
What do we do next? Do we go to Washington and talk to our reps? I mean,
I
what do
don't,
we do?
I'm not sure what the next step is. This is my first time trying to change the entire education of a profession. So,
Right.
100% sure. I've tried reaching out to academics. I've worked from the inside of NP organizations and been very unsuccessful because all my academic friends, there's no literature. Well, now there's some
Yeah,
literature, not in a published peer-reviewed journal, but there's some literature now, so that we have something that we can point to. So I think the
sure.
next step is to talk to our state representatives and try and tell them, hey, look, we need to change this. We need to fix this. We need a study. We need to, what I think would be the ideal situation, and is to hold off on any more independent practice for now until we get a study where we can say whether or not my ID may be shit. I don't know. I mean,
Mhm.
it could be really, really bad. I don't think so. I think that if we did what I'm saying, that we would have a significant value added to our profession. But I think, well, I don't know. The other thing is we may form our own national organization and try and push for it. And
Yeah,
that's something
I
that's
think
on the
that's what needs
dockets
to be
too.
done.
So,
Exactly.
I mean, right now, all the professional organizations are run by academics, and they
Or
only
they're run
believe,
by just business people
yeah,
who
or business
just
people
like
that
the
don't
NAFNAP
have
is
any
just run
interest
by
in
this.
changing anything.
He
They don't
doesn't
want to
have any,
change
yeah,
it.
exactly. Like he
MP
just
MP
wants to
schools are
buy
making
expensive
way,
shoes.
way too much money off of us right now. Way too
Exactly.
much. It's
Yeah.
become a profiteering or movement instead of a movement to help patients.
Exactly, and it's been that since the turn of the century. I wrote an article on nursing shoes, and basically when the trademark licensing came out, that's when they started to profit off of nurses, which was very, very interesting because they're like, "Oh, hey, everybody trusts a nurse. Let's get them to sell our stuff." So nurses have been influencers in a marketing space for a very, very long time. I mean, I can tell you stories of I was talking to a couple of my friends this week on how there was Bala shoes. And Bala shoes, how it started was these guys from Nike were teaching at Port or Oregon University or wherever it was, and said, "Hey, the nursing, look at nursing shoes. That's a good market, and let's get into that." So he had his students design a nursing tennis shoe, kind of like a Nike shoe, and go in. The only thing through my research that I found, here's the thing, there's people love their brands, right? They have
Mm-hmm.
brand loyalty. There's something called brand loyalty
Mm-hmm.
that he didn't understand, which I don't think they put in. And no one's just going to adopt a new tennis shoe when there's Nike, when there's Adidas, when they already had brand loyalty, and that's what I found out from my article. Hey, why do you guys wear tennis shoes, a specific brand? Oh, because I've worn 'em my whole entire
Yep.
life. So to get in with a brand new shoe, ensure they got a nurse to influence it, and he sold their first $1 million for their startup, right? Well, that he wanted in on the company. And this is all very well written and very well documented. So it's published out there. This is
Hmm.
where I got the information from. So he wanted in on the company and they said no. So he was like, fine. And he crashed them. Okay. And then he ended up passing away because he got cancer,
Oh, geez.
unfortunately, and they wouldn't help him, which was even worse for the brand, right? So they ended up selling to some other company, you know, which was unfortunate. And there's a perfect example of a company trying to profit off of the nursing profession and not even helping out. Like the guy wanted in on it. He's like, "Hey, I helped you guys sell, and without me, you wouldn't have sold any shoes."
Yeah.
And it is very true because how do nurses buy like you want to wear what the popular nurse is wearing
Yeah.
always, right?
Yeah. 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 I get it. We
But
well part of that. Speaking of them profiting, so there was a time when there was a requirement for the number of professors per NP students, and in order to make profit off of our education, they eliminated that.
wow,
So it's no longer required to have a set number of students per clinical instructor. It used to be like 10 or
interesting.
20, I can't remember what it was. And
Yeah.
then now you have these online practice management groups where
Ugh,
you hire a practice management group to teach your NPs, not your professors are no longer teaching them. It's an online practice management, which is why you have discussion boards and papers instead of the meat and potatoes of learning how to do the job. So, and it's not necessarily the educator's fault, because if they don't go along with whatever the president of the university wants, they can't keep their job.
sure.
So, and then they get a bad reputation, and then that reputation prevents them from working elsewhere. But we have to start somewhere.
Yeah,
We have to we have to fix the problem one podcast at a time, one
exactly.
discussion at a time, one share at a time. And I don't care if somebody doesn't like my idea, tell me, talk to me about it. I'm happy to have a
Exactly.
conversation about it.
You know,
Happy to have a conversation about it, because this is the result of me doing this since I guess 2016, 17 something's when I started thinking about this, and we started having
yeah,
conversations and going through that. And there's a big push for having nursing experience prior to going through NP school. And I think we should have a couple of years of critical care experience. But then I
sure.
had a conversation with one of the people on this Facebook group, Clinical Nurse Practitioners for Change, which is where about 5,000 6,000 of us are talk about this stuff all the time. And one of them said, well, so the reason that we had limited hours to begin with, he's reverting back what I've told him in the past, was because we had to have clinical experience as a nurse. Yes, yes.
Mm,
And the reason that you want to expand is because we don't have that experience, right? Yes. And we have direct entry programs. Yes. And he said, well, if we expand to 6,000 hours of training, would you really need that clinical experience as a nurse first? And I said, well, I didn't think about that.
right.
I said, that's a very solid argument that if we actually expanded to 6,000 hours, then you could go direct entry through, because technically being a nurse practitioner and a nurse are not the same profession, right?
It's
Not
true.
the same
It's not the
profession.
same
So
profession,
you're
and people
not,
get it
what you learn as a
confused all the
nurse, what
time.
you learn from your nursing experience, you do that to shorten the amount of time it would take you clinically to understand sick patients, and to understand sick versus not sick, and to understand how to interact with patients, and to understand how medicine works and how to practice, right? So, and I said that's a very valid argument. I mean, if we are changing to 6,000 hours of training from 500, then you have a valid argument that nursing experience might not be necessary beforehand. I'm
True.
like, that's a very valid argument, and I can't really shoot a hole in it, you know?
Right.
And then I had a
I think
pediatric
that's a
nurse
good one,
practitioner who
right?
said, why am I learning adult medicine through your program? She says, if I want to be a pediatric nurse practitioner, why on earth would I learn adult medicine? If I know ahead of time I want to be a pediatric nurse practitioner, why would I do that? And my argument to that was, I understand your viewpoint on that, but even pediatricians learn adult medicine when they first
Sure.
do. right? And I think the value is not necessarily learning adult medicine, but seeing sick patients and learning and going through the rotations of medicine, family practice, cardiology,
Exactly, and
and
understanding that part
surgery, and
for sure.
understanding that part. So when you go on and get your doctorate or through my thing and
Right.
get your 4,000 hours in pediatrics at that point, when you again rotate with, depending upon what you're doing, you may have to rotate through PD cards or whatever again. If you rotate it through again, you'll have a little bit better understanding, and then you'll get even more focused understanding on what exactly is going to pertain to your role. And I think that's a
Yeah,
little bit, I think so that makes sense to me, but
for
I mean, I
sure.
could see the argument too. If I'm going to be a PDNP and I just get 6,000 hours just doing pediatrics, wouldn't that be better than doing 2,000 hours rotating through adult and then 4,000 hours rotating through pediatrics?
Right.
And I said, well, that's a pretty valid argument, but I'm not quite there with you on that one yet. No, I think, and but I also think that if you get people who rotate through the first 2,000 hours as a generalist, you might end up with more pediatric NPs as well. Because I think people will
Yeah.
rotate through and they'll find what they like instead of now people are getting out and going, I'm just gonna get a job. I just need a
Right.
job. I just
I
need a
just
job
need a
somewhere. And they're
job.
just throwing,
Exactly.
throwing stuff against the wall with spaghetti, trying to get something to stick somewhere. And then they end
Exactly.
up in a job they hate, and then it takes them 3 or 4 jobs to find what they like. Versus
Exactly.
when you rotate through, you find what you like and then you head in that direction.
I think you're bringing up a great point. Well, this has been a super interesting discourse. I loved it and very well needed. We need to have more of these. So where can people find you?
Uh,
Join your
so
crusade.
I am on Facebook all over the place, just John Canion. You can join us at the Clinical NPs for Change in Facebook. Um, I'm on Twitter at Canyon John, I think is what my Twitter, I don't know, something like that. And then if you want to email me, it's jcthenp@yahoo.com. I do well, I have been very lackadaisical and haven't been on in a while, but I do some videos on YouTube that I'll
Cool.
post occasionally where I'm happy to talk about anything anybody wants to talk about. I talk about
Fun.
contracts a lot. I help NPs negotiate their contracts so we can physically discuss and go over the meat and potatoes of your contract from a nurse
Yeah.
practitioner perspective, not from a legal perspective. I'm not an attorney, but I can give you
Mhm.
advice from how how do you know you're getting paid what you're worth, right? This is one of the questions that
Exactly.
people
I
ask me
just
the
wrote
most.
a blog about that for a locum.
And
So
then they say, well, I looked at the MGMA data, which is really, really bad, by the way. Or they say, I looked online at whatever salaries.com or whatever they used, and this is what NPs are getting paid in my area. I'm like, that's great.
mhm,
Okay. But I'm going to give you from an emergency medicine perspective, kind of why I feel like I should get paid more than the average NP. So in emergency medicine, we're going to round the numbers down just to make it easy for math. In emergency medicine, the average is NP sees 2 patients an hour. It's actually 2.1, but we'll say 2 just for math's sake. And the average is a little over 3 RVUs per patient. So the average NP averages about 6.5 to 7 RVUs per hour, right? But we'll say 6 for math's sake. So I average 17. Okay.
mhm.
So 17 RVUs an hour versus 6 to 7. Why should I get paid more? Well, I'm generating you a
Exactly.
crap ton more money, right? Just an absolute crap ton. So I
Mhm.
should get paid more because at the same in the same amount of time, I'm generating. And if you look, the average reimbursement per RVU is $55 per RVU, right?
Mhm.
So if you're 55 per RVU and that patient's making 6 per hour, $300 an hour, and I'm making 17, significant difference, right?
Right.
Significant difference in the value per time. And if you can show that to your employer, then you can prove what your value is, and it gives you an idea of what you should be making and where you
Right.
should be on your value for time. So, and
Yeah.
that's easily calculable in any profession because all the RVUs are the same, right? So you just have to know
Mhm.
what your CPT code is. You can calculate your RVUs, then you can calculate your value.
Right, right.
Pretty
I had
easy.
a friend do that, and I negotiated his contract with him, but he was seeing like crazy patients in an urgent care. He would see almost 90 in 12 hours.
Woo!
Well, that was,
Okay.
yeah, it was insane. Like sometimes he would tell you, he's like, I just saw 90 today, but he averages now like 45, 50, which is a lot, but he was the highest
That's
paid.
still a
Yeah.
lot for an urgent care.
Yeah,
So
it's a lot. Yeah.
that's a really good example. So I'm going to give you the numbers on urgent care, right? So the average person in urgent care sees 28 per day. Okay.
Mhm.
Um, so, and the average urgent care is 65 to 75 an hour, right? So
Mhm.
if you're making 65 an hour of an urgent care and you're seeing more than 28 a day, you're getting robbed, right? Absolutely
Mhm.
robbed. The most I ever made in an urgent care working in RVU models 166, 64 an hour, right?
Mm.
And that's because of the RVUs that we did in addition to our base salary. Base salary was low, but because of the volumes that we were seeing, we made good money because of the contract. And you
Yeah.
can
Do you
do
know how
things
much
like
my friend
that.
was making?
Huh.
Because he was working for a shady FQHC, and they've been, taken
Hmm.
taken down. So, and I'll say it, he was making 350,000, almost 400 grand a year.
That's
Yeah.
pretty easy to make good money if you have a good RVU contract. It really
Yeah,
is.
yeah.
And
Yeah,
you should
so
be really, if you're seeing 60 plus patients a day,
mhm.
you should be making that kind of money
Oh, yeah, yeah,
because
he
you're
was
you're
he was well
absolutely
worth his
killing it. You're
pay.
killing it,
Oh, yeah, he was generating massive income
massive
for
amounts of
them.
money for your employer.
Yeah,
And
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 because
those
he
kinds of things are
yeah.
all about the RVUs, right? If the RV and
Mhm.
understanding RVUs and understanding what you get paid and what you should get paid and all that kind of stuff really, really makes a benefit. Remember, we talked about CME earlier, and we were talking about how
Mhm.
people were getting like 500 CMEs per year reimbursement in their contract.
Right.
Industry standard is 2,500 to 5,000.
Wow.
So that's industry standard. So if you're not making that, your employer is ripping you off.
Right, for sure.
So you have to understand those kinds of things. And the problem is it's not published anywhere.
Yeah.
Why? Because they
Nobody
publish what they
wants you to
want to, and
know.
nobody wants us to have that information. And like MGMA,
Sure.
MGMA is one of the national organizations that polls for salary data, right? And
Mhm.
I know their data is crap because I physically, not literally, physically negotiated all the contracts in the ER in this region that they
Mhm.
covered, and the salary that they quoted for that region was $45,000 and at $45,000 a year less than what we were
Wow.
making. And I know because I literally negotiated all the contracts in that region. So I know
Mhm.
exactly what the value was. And it was $45,000 a year less. And the next year it came out $55,000 a year less.
Wow.
And you know what those guys made? They made 10% more the next year. So, I mean, data is what it is and data can be manipulated, right? So
Sure.
whoever's responding to the survey is the problem, right? So if you have people responding to the survey and they're giving incorrect information on a survey, then you're getting incorrect results. So part of the problem is nobody has this. And believe
Yeah.
me, guys, on my list of things to do is to develop a salary, uh, I'll do a salary review at some point. That's on the list of things to
Yeah,
do
that's
in
awesome.
time. So that
Cool.
way we can get that out. But that's a little bit further down the road because education is more my focus at this time. I'll try and get something like that out because I negotiate
Sure.
on average about 3 to 500 salaries, 3 to 500 contracts a year. So
That's awesome.
I have some kind of idea of what it is nationally. So I get an
Cool.
idea and I can try and get something together and we'll sort something out at some point on that. But that's
Great.
that's on down the road. Anyways, it's
It's
great
been
talking to you.
super fun.
Yeah.
Yeah,
We'll have to do it again
and,
sometime.
like, yeah, definitely, we'll have you on again, and see what happens, but this is awesome, so thank you so much for listening, everybody. Till next time.